Welcome, everybody, to the In It for the Long Haul Club. It's a very special day today because we have our very own beautiful and wonderful and brilliant Dr. Robbie here, who is a clinical psychologist and also a long COVID sufferer herself. And she's going to be talking to us about neuro-COVID and its effect on cognitive, psychiatric, and psychological aspects. So I'm going to introduce myself briefly, and I'm going to hand it to Katie to introduce herself, and then we're going to toss it over to Dr. Robbie. So my name is Dr. Alice Perlowski. I am a cardiologist in the Los Angeles, California area. I am also a long COVID patient. I've been suffering for about 19 months. My most concerning residual neurological issues include severe fatigue, and then most recently, the dysautonomia has been pretty profound. So I'm weak and dizzy a lot of the time. So Katie and I started this club, the In It for the Long Haul Club, a few months back, geared towards long COVID patients, but also for the support of people with other chronic illnesses who have been extremely helpful to us during this time. So I want to remind everybody in the audience that this is slightly different than what we normally do during these rooms. This room is being recorded. So if you do come up on stage and ask a question during this room, you will be recorded and you're consenting to be recorded. What Katie and I would like to do is have Dr. Robbie's presentation, have some questions and answers intermixed through that time, and then we can shut the recording off and just have a normal room. And I think we just, lost Katie. So I'm going to hand it over to Dr. Robbie to introduce herself. Go ahead, Dr. Robbie.
Hi, everyone. It's Dr. Robbie, and I am going to claim dual expertise today as both a clinical psychologist with 25 years of licensed experience and a COVID long hauler for 515 days, a Delta survivor 66 days ago infected, and 14 days into a new COVID infection because I left New York and came to Florida the same day that my mom was hospitalized with COVID, and they discharged her the next day home to me. And 6 days later, I got sick. So good times here. So thank you, everyone, for being here. I'm going to do my very best today. And I know everyone is appreciative of all of our opportunities to learn on here and will be very forgiving of any glitches that I may have along the way in my cognitive dysfunction. And I will definitely do as well as I can. So I'd like to start off by giving a disclaimer. And I am a licensed provider in a lot of states, and I am not offering any medical advice here. I'm simply sharing my own personal experience and my knowledge as a psychologist. So none of us as doctors are allowed to give individual advice or recommendations or make diagnoses or give treatment recommendations to anybody specifically, but we can simply talk about things in a general way. Okay. So today my presentation on neuro-COVID and the brain is data that I'm going to present from my continuing education program that I participate in with the Loria Neuroscience Institute, and Dr. Elkhanan Goldberg is the professor that I study with, and I have been doing their curriculum for many, many, many years. So in addition to that, I'm also sharing knowledge that I have as a COVID long hauler who's participated in the Mount Sinai Center for Post-COVID Care for the last 11 months of my 17-month journey, and also the journal articles that I have read along the way, and so my general knowledge and experience. So I'd like to talk about COVID-19 pandemic and then the Delta variant as well. So as of earlier this morning, October 2nd, 2021, we had 700,275 Americans who have died. This pandemic is now the deadliest in American history, overtaking the 1918-1919 so-called Spanish flu. So many million Americans have been affected, and Delta has now ripped through the unvaccinated and has resulted in breakthrough cases. In August of 2021, every age group under 55 had its highest death toll of the pandemic. The CDC has so far identified 2,900 people who were vaccinated among the 100,000 who died since mid-June. We don't know the percentage that will become Delta long haulers, and I think that's really important because, of course, these death statistics are horrid, but so is being a COVID long hauler. And I think a lot of physicians have yet to realize and recognize that, and sadly it is our job as the patients to try to educate our physicians, because we have to collaborate, because we are the ones who are suffering. We have the most skin in the game for learning about COVID long haulers. And primary care physicians in particular are extremely busy with everything, and they don't necessarily have as much time to read all the journal articles that those of us that are home and disabled or unable to work full-time or part-time or at all have the time to do. So we do need to be teammates with them. So I encourage everyone to do that. So in this talk, I'm going to attempt to summarize what's been learned so far about the neurological, cognitive, psychiatric, and psychological impact of COVID-19 on the brain. And this knowledge will undoubtedly expand, and I'll certainly update this presentation as new findings and new theories emerge. Originally, COVID-19 was characterized as a respiratory illness, and the most commonly reported symptoms in the beginning were fever, fatigue, dry cough, and shortness of breath. However, we already knew that the heterogeneity of COVID-19 symptoms has been increasingly recognized now, and not all of them are respiratory. Increasingly, neurological symptoms are being documented. It is my opinion that this is, in fact, a neurological disease process, and I'll try to make a case for that in some of the things I'm going to share today. I also want to mention that while I don't refer to myself as a neuropsychologist, I could technically qualify to call myself a neuropsychologist based on my education and training, but I have not done a fellowship, a postdoctoral fellowship in neuropsych, and for me that would really be the gold standard. There are plenty of others that will call themselves neuropsychologists just because they meet the bare minimum standard, but I am not that person. I consider it to be the gold standard to have done the 2-year postdoctoral fellowship in neuropsych before one calls oneself that. However, saying that, I did a neuropsych dissertation, and I have been very interested interested in neuropsychology my entire career, but I haven't had the time because of my career, firstly as a Navy psychologist and then into private practice, to go back and do a postdoctoral fellowship. So I would like to talk about the symptoms that the CDC identifies as COVID-19 symptoms: fever, cough, shortness of breath, difficulty breathing, chills, repeated shaking, muscle pain, headache, sore throat, and new loss of taste and smell. It's important to recognize that there are lots more symptoms than those, as we all know. And that's because multiple organs have been impacted in COVID-19. And these include the lungs, the heart, our blood system, our digestive system, our brains, liver, kidneys, the skin, musculoskeletal system, and our mucous membrane. So what does coronaviruses do to the central nervous system? There is a growing recognition that coronaviruses in general and other respiratory viruses can invade the central nervous system. And this was in an article in a journal called Viruses, published by Desportes et al. In 2020, titled Human Coronaviruses and Other Respiratory Viruses, Underestimated Opportunistic Pathogens of the Central Nervous System. People didn't realize that the general population, virologists have known this, but the general population of physicians and humans didn't really know that viruses were crossing the central nervous system unless you were somebody who was involved in studying MECFS. Then those physicians have been well aware of it, but it's been profoundly underserved community. So now we understand that there can be multiple ways that COVID-19 is impacting the brain. And some ways it affects the brain is through direct infection, and others through secondary mechanisms, such as our autoimmune response. So it's really complex what's happening in our brains. So the presence of SARS-CoV-2 RNA in patients' cerebrospinal fluid had been reported in the Journal of Therapeutic Advances in Neurological Disorders in March of 2020. And that's a really important piece of information to understand. And so the roots of infection are believed that direct invasion of the central nervous system by the viruses are carried by the blood and crosses our synapses involving certain cranial nerves. And everyone knows about the olfactory nerve because there's been a lot of talk about how this gets into our brain through going up our noses through our olfactory bulb into the olfactory nerve, and then completely appears to go throughout the brain. So the blood-brain barrier is another way that SARS-CoV-2 could be spread. And we know that the blood-brain barrier can be crossed via two routes. One is infection of our leukocytes, which are white blood cells, a type of white blood cell, and that can cross the blood-brain barrier, and infections of endothelial cell linings of the walls of blood vessels. So the nasal route that we all have heard so much about is the virus goes up our nasal cavity. It affects the olfactory nerve and the olfactory bulb, and then a part of our brain that has a really cute name, which is the piriform cortex, and that relates to our smell, and impacts our brainstem, which regulates heartbeat and breathing.
I have to say that it's incredible that Dr. Robbie is able to speak so articulately in such scientific language, considering what she has had to deal with her long COVID journey. So we really appreciate it. Take as much time as you want. I'm actually going to have Katie introduce herself because she was having some technical difficulties. And then maybe we'll take a couple questions from the audience. Is that okay?
Absolutely.
Okay, perfect. Okay, go ahead, Katie.
Hello, this is Katie speaking. Please interrupt me if you can't hear me. I have tried everything, including mobile versus Wi-Fi data, but I seem to have a good spot right now. For those of you who don't know me, my name is Katie. I am Australian, but I live in South Africa. I contracted COVID about a year ago. To be very brief about my journey, I was finishing my PhD in science. I've been working in science for almost 20 years. I was publishing scientific papers, wrapping up my PhD. A lot of my PhD is in genetics, and the only reason I'm throwing that out there is to give you a bit of context. So I went from analyzing genomes one day to contracting COVID, hitting the floor and not being unable to understand how to read or write even a text message for about 2 months. So it had severe cognitive effects on my ability to work. I still struggle to use a computer over a year later as someone who used to work young, fit, healthy, using a computer over 12 hours a day in the lab, in the field, everything like that. So I won't go into much more of my journey, but I just think it's relevant in terms of the cognitive and ability and changes in my brain since contracting COVID. So I just appreciate you all being here. While I have the mic, I would just like to also remind everyone that this session is being recorded. If you want to ask questions, my internet's a little bit glitchy, so it'd be great if you want to remain anonymous. Please DM Dr. Alice, and we can pass on those messages for you. We have a lot of our normal long COVID friends in the community here, and we can have a chit chat after this recorded session is finished. But also, if we're bringing you up to stage, we will be having questions and answers. Just please be patient, and we'd also love you on stage just to hang out, let others see this. Also, please ping other people into the room. I don't seem to be able to. So this is a really, really important topic. We want people to understand the severity of contracting COVID and long COVID, even over a year out. Particularly, I think, at least the top 3 people here on stage have been over a year with COVID, and it's impacted our lives. So we just really want to convey how important this message is, and for people to take this illness really, really seriously. So thank you so much for listening. I will turn it over to you, Dr. Alice, but thank you so much, Dr. Robbie. I know you're navigating your own health journey, and just appreciate your time, your energy, and your expertise.
Hi, this is Dr. Alice. I think we'll take a couple questions from the audience. If you could please state your name, a very brief description of yourself and why you're interested in the topic, and then your question. That would be great. Go ahead, Jody.
Hi, my name is Jody. I'm COVID long hauler, experiencing long haul COVID for a little over 18 months. Dr. Robbie, thank you so much for what you shared. It actually really calms me down a lot. I initially remember the first week of my acute COVID phase, which was mild. I remember the day that I lost my sense of smell and taste was the same day that I had an out of the blue, really extreme panic attack. And back then I just thought, I had a panic attack maybe 20 years prior. And so I knew what the symptoms were, and I knew what to do to sort of get myself off the roof. But now looking back, I realized, and no one knew this then, my brain was being affected. My nervous system was being affected right then and there. And I have had my biggest I have a lot of the other long haul symptoms that are really debilitating, but the one that's really making my recovery most difficult is my inability to get restorative sleep. And since I've been experiencing this illness for so long, I've really been looking into ways that I could, with professional help myself with this PTSD, which I know that I'm experiencing. I am working with a regular therapist. I am working with doctors to look at my endocrine system, which has been trashed from this thing. I'm no longer producing cortisol, but I'm still having problems sleeping at night. So I just wanted to get your opinion on what you have found for yourself and for other people that you work with to really help with either sleep issues or with PTSD. This is Jody, and I'm done speaking.
Thank you, Jody. I really appreciate those questions. They're really, really important and definitely perfect for this discussion today. I'm so sorry that you've been suffering for more than 18 months. So you can be in the top line with the other three of us. I might be the baby up there at 17 months. But you brought up something really essential that others may not realize, that you had the change in your ability to smell and taste, and then you had a panic attack out of the blue, and not having had one for 20 years, that was definitely out of the blue. So you hit it right on the head when you said that your brain was being affected. It absolutely was. The non-restorative sleep is one of the sequelae of long COVID, and as is PTSD, and we'll hear we'll talk more about all the other things as far as anxiety and depression and psychosis, a whole host of issues. My opinion on sleep, well, I'd say for the first 7 months, I didn't sleep more than an hour a night and did not sleep at all during the day. So I was living on an hour's worth of sleep. I was hypoxic and came to learn that through this whole process of my lung injury, etc., that I developed sleep apnea. So I would always encourage anyone who's having sleep issues to see a sleep specialist and really ask them to not disregard you as, you couldn't possibly have sleep apnea. I can't tell you how many doctors looked at me as a 120-pound woman who was very fit and athletic at the time and said, there's no way you could have sleep apnea. But when I got to Mount Sinai, they immediately assessed me for sleep apnea. And when the other doctor said I didn't meet the criteria, so we've got to have COVID-aware physicians in every aspect of our bodies, including our therapists, that can help guide us. So my neurologist has prescribed me 4 different medications. And he loves to remind me that I am his first patient ever that he's given 4 sleep medications to. And they cover 4 different neural pathways of our brains, which was really quite brilliant. And through that, and finally adding one thing that I did not want to add, but was forced to add because I couldn't get any more than 3 hours of sleep on the 3. We added a 4th medication, which was a benzodiazepine, and then together I was able to sleep, not in a row. I still don't sleep much in a row, even with the CPAP and an oral appliance, because I failed CPAP alone. For someone who couldn't possibly have sleep apnea, I have severe sleep apnea. As far as PTSD, I happen to be a PTSD expert, which is going to come in handy in treating folks around the country that are suffering with PTSD, either because they are a survivor of COVID or a COVID long hauler or a family member of someone who didn't survive, or just happens to live on this globe and has suffered suffered a worldwide pandemic that has caused such trauma to our lives. So I think PTSD needs to be taken very, very seriously. And my bias, because of what I do for a living, is that we try to use psychological interventions, but in some instances, we do need to do a combination of medication with psychological treatments. So there's psychiatric intervention and psychological interventions that often need to be combined. And in many illnesses, it's the gold standard that it needs to be combined. For instance, severe depression, it's a gold standard, whereas mild depression, therapy would be indicated rather than a medication. So PTSD is unfortunately, I'm sad to say this, but it's not something we actually recover from. It's something that we can get into remission, however, and we can manage it very, very well, and we can feel as if we've recovered. But it's actually, the data doesn't indicate that we fully recover from it. And I can answer questions about that if anybody has any, but I won't go into depth. But there are lots of treatments for PTSD, and I happen to be certified in what's called eye movement desensitization reprocessing, EMDR. And that is a technique that uses bilateral stimulation to help move things into the proper filing cabinet in our brains, which is the hippocampus. So it's important to get our amygdala, which is where all of these trauma memories are kind of being held, if you will. They remember it's part of our brain, our fight, flight, or freeze response we are born with, and we never lose. We actually our brain stores memories of things that have been life-threatening or endangering to us, so that we will recognize the signs and symptoms, so that we can run if we can get away, we can fight if we have the ability to win the fight, or we can freeze and play dead if the other two things won't work. So EMDR is a really effective treatment, but cognitive behavioral therapy, there are lots of them, are also very helpful in the treatment of PTSD. So if you're interested in looking for a PTSD therapist, you can go on to the EMDRIA website and you can search for a therapist. You can also go on to Psychology Today and search for an EMDR therapist that way. That might be a little bit easier. There are also therapists that are out there that are specialists in, historically they are treating people that are dying from cancer or who have survived cancer or have other really severe chronic diseases. And now they are working with long haulers. And I work with a therapist who's part of a group that Mount Sinai referred me to called Inspire Wellness. And if anybody's interested in their contact information, you can let me know, but you can just Google them. And they have telemedicine and they do accept insurance. So that is something that might be helpful to you. Jody, I hope that answers your question. If I forgot something, please let me know. Dr. Robbie out.
Thank you so much, Dr. Robbie. First off, I just want to say, just hearing you talk about medication really is so helpful. I am someone who was not on medication before, and so I am currently on a benzo as well. That was actually initially prescribed for me from my first cardiologist when I had pericarditis, and I stopped sleeping for like 28 days straight. 14 days straight, and then another like 15 days straight. So I have had to use that, and I also have had PTSD in my past, in my childhood. So I have what's called complex post-traumatic stress disorder. And thank you for just dispelling the sort of fear that I have around these situations. And the shame that I have felt about having to be on medication. It's been a really big sort of like anxiety point for certain members of my family, certain friends. I, prior to getting COVID, could never have imagined that I'd have to be dependent on medication for survival. And so I can't thank you enough. So I tried to get into the Mount Sinai sleep study, and they can't get me until March of 2022, which is kind of a bummer. I will look for other sleep studies. But I also wanted to thank you for mentioning about the medications. And I just want to put it out there to some people, I unfortunately did fortunately did genetic testing prior to starting medications and found out that I don't have a certain liver enzyme to process like 90% of the really well-tolerated drugs that people can, like trazodone. So I have a bit of I'm a juggling act right now, but I am getting some sleep. I am having to use a combination of some over-the-counter things and some prescription things. But just hearing you talk about that there's no shame in this game, especially as a long COVID survivor, and that I can, at least remove that emotional aspect of my recovery, that I survived COVID. I probably should have died many times over. I haven't, and that I'm doing the best I can, and that I do have a CBT therapist, and I did get a recommendation for an EMDR therapist. So it just gives me some comfort to know that I'm doing all the right things. And I just feel really grateful for this community. This is Jody, and I'm done speaking.
Hi, this is Dr. Alice. I'm so sorry, Dr. Robbie. Thank you so much, Jody, for all that amazing insight and for sharing your story. It's very valuable for everyone to know that they're not alone in this process. So what I wanted to just mention is that none of the things that we are discussing constitutes medical advice. Please go to your physician who can evaluate you and examine you to determine what medications or therapies are most appropriate for you. Everybody is different, especially with long COVID. It seems like we have a lot of similarities, but we also have a lot of differences in, our presentations and things like that. So please go to your primary doc or your specialist to ask if any of the medications or therapies discussed are appropriate for you. Okay, we're going to go to Shelby next. We'll take one more question from her, and then Dr. Robbie, you can go on with the rest of your presentation. Okay, go ahead, Shelby.
Hi guys, my name is Shelby Hedgecock. I am a long COVID patient for almost 18 months now, and I'm also the founder of Blooming Magnolia. We're a long COVID support and mental health advocacy nonprofit. So as y'all can imagine, this is a pretty serious and important topic, in my opinion. So Dr. Roby, you know that I love you to death, and I there's a bunch of people on stage here, so I want to be respectful of time, but I kind of want your input on this, and just to see kind of how you're feeling in regards to this information. So earlier this year, the Lancet posted a study on over 200,000 people who were diagnosed with COVID-19. And the paper concluded that 1 in 3 received a neuropsychiatric diagnosis within 6 months. So as a clinical psychologist with over 25 years of expertise, how alarming is this for you? And in your opinion, how will these severe issues affect our population long-term in children and adults?
Well, Shelby, firstly, I want to say thank you for asking that great question. I actually talk about that article in my presentation, and just haven't gotten to that yet, but I will definitely address that in a really deep way. I want to say thank you for asking that question, and I think that we have to recognize that Lancet posted that extremely numbers are astronomically higher now. We know that as COVID long haulers because we've been in these groups for 17, 18, 19 months, right? And so I see it in all of us that as we share our stories on our platforms, and we've got to get this out into the mainstream so that people understand the impact, the neurological impact that COVID has had on all of us. And I also would like to just circle back to Jody and say thank you for being so courageous in sharing that you do suffer from complex PTSD. And thank you for also defining what that is for people. I think that's really helpful that you did that, and just so courageous. And we should probably say it multiple times. I said it in the beginning, and Dr. Alice said it a few minutes ago, that we're not making any recommendations to anyone to do specifically, because Jody brought up this great example of why we don't do that. She's had a pharmacodynamics test that's told her that 90% of drugs, she doesn't have a protein or an enzyme or a gene or something to be able to find effective. And so I like to remind people that that's why we call it the practice, right, of medicine or psychology or whatever it is, cardiology. Dr. Alice, we're practicing. So that's a cute little joke for, we have to work through it. We have to work through with our providers who know us, who understand us. And I can't make any psychological recommendations to anyone specifically because I haven't done a thorough psychological evaluation on you. And it would be unethical to do that. So I'm just talking in generalities today, and we'll just continue to remind, because new people come in, and we want to make sure that people understand that. Okay, does anybody else have any questions before we move on?
Hi, it's Katie speaking. Thank you so much, Dr. Robbie. If you don't mind, I just want to take a moment, as we do have a few people in the room, just to give a little bit of context and background about what we're doing. We are joined here today by Dr. Robbie, who is a clinical psychologist and also a long COVID patient. What we're doing is discussing what the science has discovered so far about COVID and the psychological cognitive effects and what it does to the brain. We also have many long COVID patients here in the room discussing our personal experiences, as has been brought up and we'll bring up several times. None of this is constituted as medical advice. However, we are communicating the science and our personal journeys, and based on the published data has been done so far. So thank you all for being here. We will have time for questions, but for the moment what we're going to do is have Dr. Robbie go through a presentation about what we know in the science so far, and we would love to have you up and ask questions thereafter. So thank you for being here, and I will turn it back over to you, Dr. Robbie. Thank you so much. It's Katie Mountain speaking.
Hi everyone, it's Dr. Robbie. And next I wanted to talk about the emerging spectrum of COVID-19 neurology. There was a study done in the UK. It was published in the journal Brain in 2020, and they identified 5 major categories of neurological disorders. So they are encephalopathies, neuroinflammatory syndromes, peripheral nerve system disorders, stroke, and hypoxia. And so So I think many of you have probably had some combination of these things, as I know I have, and I know also Dr. Alice has, but I won't share her story. I'll let her do that, as well as Shelby and Katie. So that's really important that we know that there are studies being done. I also wanted to say to Shelby, her question about the Lancet, I went and looked to see whether their clinical trial is done. The Lancet has a COVID-19 commission, and I was not able to find any updates. So we'll just continue along here. So as more and more time passes since the beginning of the pandemic, we're in a much better position to assess the long-term effects of COVID-19 on the brain. And what was, as the Lancet article predicted, it was really a dire prediction a few months ago. It's really become an empirical reality now. So one of the big things is this persistent brain inflammation. And there's data that shows that the brain inflammation was likely present as early as 3 months after recovery from acute COVID-19. And the neurologic sequelae were found as early as 6 months. And these studies were done in 2020 because there's not been a lot. There's some, but nothing that's really new. That's, there are a few things that are new, but not a lot. So at 6 months follow-up, people have reported a wide array of neurological symptoms. And I'll tell you what those symptoms were. This study had 165 patients in it, so it's a small cohort. But these things will sound familiar. So the symptoms include fatigue, 34%, impairment of memory and attention or both, 31%, sleep disorders, 30%. So this is really, really significant. Neurological symptoms have really been a huge issue. Formal neurologic exam of those patients, the 165 patients in the study, 37.4 of the patients exhibited neurological abnormalities, including cognitive deficits, hyposmia, and postural tremor. And a lot of people have brought up the tremor and wondered, as early as 6 months in Italy, they knew this tremor experience was happening. And it was a long time before people recognized it here in the United States. Shelby can probably attest to that. We also found that the median onset of neurological sequelae occurred within 186 days. That's quite interesting, right? Fatigue or muscle weakness occurred, and sleep difficulties were the most common symptoms. This is a study done in China that I'm talking about now. Anxiety and depression was reported among 23% of the patients in their study. It was 1,733 patients that was enrolled in their study, and the median age was 57 years old. And 52% were male. So that was kind of fun because so many of the studies have more women than men, and this had more men. And so men are also experiencing the neurological sequelae as women have been. So one of the reasons that there is such a neurological problem is that they have identified 3 brain structures that appear to be particularly vulnerable. And I'll tell you a little bit about what each of those things are. So the mesial temporal lobe, which is the hippocampus. And it's hippocampi, there are two. And they appear particularly vulnerable, increasing post-infection memory impairment. That's what the hippocampus, as I mentioned earlier, is for. I like to think of it as a beautiful file cabinet that has all the folders, have those pretty typed labels, and they're color-coded, and they're in there chronologically. They just look spectacular. As compared to the amygdala, which is the file cabinet dumped on the floor in the great big heap. And so we've got to get things into our hippocampus, but you see, it's very vulnerable in COVID. Our frontal lobes are also very vulnerable, and that's where Dr. Alice was talking about some of her symptoms, and many of our symptoms are Katie also talked about this, the cognitive impairment that are called executive functions. And those things that control our judgment and planning and time management and the ability to organize things are impaired when our frontal lobes aren't working. And the brainstem is also very vulnerable to COVID-19. And so it's important. The brainstem controls our heart rate and our breathing. And as most of us know, that is, those two things are extremely familiar to us as long haulers, right?
Let me just reset the room here. Welcome to everybody who's new to the room. This is the In It for the Long Haul Club. Katie and I started this club several months ago for support of people who are experiencing long COVID. Long COVID is defined as having symptoms greater than 4 weeks after initial COVID infection. People have symptoms from head to toe, but some of the most concerning symptoms or the neurological ones, which affect 1 in 3 people who have been infected with COVID. Many of us up on this stage have had significant cognitive issues as a part of this, personality changes, neuropathies, weakness, and something called dysautonomia, which means the nervous system that controls the heart rate and blood pressure, the things that you really don't think about that you can control, gets completely out of whack. And so people have heart rates that skyrocket into the 150s just by standing up or folding laundry. So you can kind of appreciate how uncomfortable that would be for those of us. Most of us were completely healthy prior to getting this illness. So it's a significantly debilitating illness. There have been studies that have come out that several people, probably about half of people who are suffering from this, are having trouble going back to their full-time employment that they did before. People are becoming financially insecure. They're having to apply for disability. They're having trouble paying medical bills because the cost-sharing aspect of COVID ended in the beginning of 2021, and so this has become a significant, I would say, life stressor for just about everyone dealing with it. Katie and I strive to have these rooms to educate people about long COVID and to emphasize how real and serious this is. There are several misconceptions that are running all around the globe that long COVID represents hypochondriasis, meaning people thinking they have symptoms when they do not. And I can assure you that just about everybody that we have in our group who have long COVID have had objective evidence of significant disease, meaning findings on brain MRIs, meaning findings on laboratory values, evidence of organ dysfunction, that kind of thing. So, hypochondriasis and anxiety, of course, are things that need to be addressed and are present. However, COVID-19 affects basically every organ system in the body. So I just wanted to reset the room this is a very special session today because we have Dr. Robbie, who is a clinical psychologist and also a long COVID patient who is exerting her extra energy today trying to educate us about what she knows about the neurocognitive effects of COVID-19. So I really want to thank her for being here. And I'm just going to pass the mic to Katie, and then we'll take a few more questions. This is Dr. Alice. I'm done speaking.
Hi, it's Katie speaking. Thank you so much, Dr. Alice, and thank you, Dr. Robbie. We really appreciate you sharing your expertise. And as a fellow long-haul COVID person, I know how much it takes as well to exert that extra energy. But I know you're just as passionate as we are about getting this message out about how severe and debilitating this condition is. There's a lot of misconception that long COVID is just, as Dr. Alice said, like a little bit tired or something like that, whereas, I'm a year down the track and I'm still unable to work. So I just wanted to acknowledge the people that are on stage. We have Samantha, Rohan, Mandy, and Jody, who's spoken before, and of course Shelby too, who just asked a question. So if anyone would like to come up, what we're doing is having like a few intermissions with questions, and then Dr. Robbie will come back to all the knowledge that we have, all the scientific community and medical community, I should say rather, has about COVID and long COVID, particularly with the cognitive and psychological effects. So if you have any questions, please feel free to either raise your hand or hold on a little bit and we'll bring you up, and we really appreciate your patience waiting, but we really want to get to some of the knowledge because your question might be answered as well. So Samantha, did you have a question, my love? If so, we'd love to turn to you. It's Katie, I'm done speaking.
Hi, yes, this is Samantha speaking. I did have a question. I know everything is new and we're still figuring out things as we go along, but for like the psychological aspects of COVID, do they seem to be like based on other things like self-resolving, or do they need to be like, do you need to have medication for them to resolve, or can they be self-resolving? Again, I know this is not medical advice, I'm just wondering, based on different things that I've heard from different people, can psychological things self-resolve? Thank you, Smith. I'm done speaking.
Thank you, Samantha, for that great question. I really appreciate you coming up and asking that. Well, it's important to understand that mild psychological symptoms can resolve on their own untreated. So historically, that's what the research has shown us. More mild to moderate, and moderate and severe. Severe tends to not resolve on its own without a combination of medication and psychotherapy, which is typically the gold standard depending on what the illness is. But even people with mild symptoms can really benefit from some brief psychological therapy with a psychologist or a social worker or a licensed professional counselor or different things. Around the country, they have different titles. So in California, they have a class called NFCC. So they have all kinds of different therapist levels around the country. And even a mild symptoms could be resolved more quickly with some intervention. So I don't think we know, Samantha. You pointed that out quite astutely. What is going to happen long term with the psychological sequela? We just don't know yet. It's being studied, but this is very early in a research process, because to do the kinds of studies that are required to, really are taking time. So that's why you see a lot of studies that are reviews of the literature that have small cohorts in their studies, because we just don't have the time yet. But of course, those of us that are suffering, we're like, come on, give us give us something here. We need treatments. So what we're finding, though, is that in treating the sequelae of COVID-19's neurological impact, as well as people who weren't affected, that never contracted COVID-19, we see a lot of psychological issues for the entire world population. Everybody's been, has experienced a traumatic experience. We have this universal traumatic experience that we've all shared, and we shouldn't minimize that. So I think we're yet to know. I have some things I'm going to talk about, and when I get to the psychological aspect of it, so I'll go into greater detail. But I hope that answered your question, Samantha.
Yes, it did. Thank you.
You're very welcome. Are we going to take another question, Katie?
Hi, it's Katie speaking. Thank you so much, Dr. Robbie. I just want to ensure that we're, conserving your energy and everything like that. We have Rohan, who I think might be busy right now. But if you would like to, Mandy, if you wanted to ask a question, or if you're happy to wait and hang out here, perhaps we should let Dr. Robbie go on with her presentation, and then we can ask questions afterwards. And while I have the mic, I just also wanted to remind you that this is being recorded, as is in the title, and part of Clubhouse guidelines. Now they're doing recordings of groups anyway. But just if you had a question and wanted to remain anonymous, you're more than welcome to directly message Dr. Alice and ask a question, and we can read it out to you, either from the audience with your name or anonymously if you like to. But Mandy, are you okay if we continue with the presentation? If you don't respond, I'll assume that's a yes.
Yeah, y'all go on.
Okay, perfect. Thank you so much. We'll turn it over to you, Dr. Robbie. And yeah, just no pressure at all. If you need to take a break or wrap up, then we're fine with that too. Thank you for taking up that speaking. Over to you.
This is Dr. Robbie. I'm okay. I got some more drinks lined up here because I had run out. So we're good to go now. I wanted to talk a little bit more about the neuroanatomical vulnerability that I mentioned. What Dr. Goldberg from the Loria Neuroscience Institute says is that the vulnerability to these brain structures is due to the enduring brain inflammation, and in his view, a breakdown of the blood-brain barrier. And so he mentioned that a lot of us are experiencing microclots, and that is causing these injuries in our brains as well. And even though we may not have a full-blown stroke, which I'll mention a little bit later, many of us are having these little microclots in the small vessels, and that's causing impairments. Next thing that I want to mention is that there is cerebellar impact, but it doesn't seem to be as common as the frontal lobe impact. So I think we have to keep that as an important thing. There was a study that came out in the Journal of Medical Neurology that was a case presentation, and this particular patient presented. He was 74 years old with severe COVID-19. They were confused and agitated. The person did not survive, but that's how they presented to the emergency room, as confused and agitated. And then they did the swab and found that they had COVID. So I think that's very, very interesting. So the postmortem analysis and the autopsy showed SARS-CoV-2 viral particles in the frontal lobes. So this was early on in April of 2020, which demonstrated that it wasn't just inflammation, it wasn't just immune response, but viral particles were found in the brain, and the drowsiness, just being so exhausted. And a study was done in France published in a journal called Ellipsia, which I think is a French journal, in June of 2020, and it revealed the frontal lobe involvement, and behaviorally the patient presented with verbal perseverations, which means that you repeat the same thing over, and I expect to see some flashing lights on that one, because you're trying to ask somebody to do something and you just keep saying the same thing over instead of coming up with other words to express what it is that you're trying to communicate. Anybody else up here have that happen to them? Yeah, certainly happens to me still. As well as echo behaviors. Echo behaviors is where you repeat what someone else says, so that's really quite severe. And then the drowsiness. So the Journal of Neurology in July of 2020 presented another example of frontal lobe issue, which was encephalopathy. And so I mentioned that as one of the significant problems that we have. A little bit more about the hippocampus, which is in our temporal lobes, one on each side. And I don't know if I mentioned it earlier, but it just popped into my mind. So if I'm repeating myself, I'm sorry. But all coronaviruses and other respiratory viruses as well, including MERS, SARS, herpes, HIV, and now SARS-CoV-2, are vulnerable. The hippocampi is vulnerable during that. So that's really important that we understand that. Seizures are also a possibility. I don't know if anyone on the stage has had seizures. I have heard other people in the rooms talk about seizures. And so seizures are more likely to occur with COVID-19. Okay, I also want to mention a little bit more about how the neural mucosa interface occurs. We talked about that earlier. So SARS-CoV-2 appears to follow neuroanatomical structures. So it penetrates the brain, and it includes the parts of the brain that control our respiration, our cardiovascular control center, and the medulla oblongata, and the pons. So we know that there are many points, and we know this because of autopsies. So we also know that there is persistent brainstem inflammation. And so many of us are continuing to have heart rate issues and difficulty breathing. And we go and we get see the cardiologist, and they tell you, oh, your heart looks fabulous. You don't have any issues whatsoever. You look great. But as Dr. Alice was sharing, until you stand up and then your heart rate is whatever it is, if I take a shower and put my hands over my head to wash my hair, my heart rate has gone up to as high as 224. So that's just absurd for trying to wash your hair. But we also have this sense that we can't breathe. And then you go and you get pulmonary function testing done, and they say, oh, you're doing just fine. I can't tell you how many people have told me that in our support groups and here on Clubhouse, mentioning that they they go and they get their testing done and everything looks fine. Their lungs look good. They listen to their lungs and they say, oh, everything sounds good, so they don't even get any additional testing done. So I was very fortunate that I participated in so many studies at Mount Sinai that I've had essentially every one of my organs examined under very high magnet MRIs and even PET scans. So I encourage people to try to participate in studies because that may give you answers. Because if you do have something that they find is wrong, they will communicate that to your physicians because it would be unethical not to.
And the third area she mentioned was the temporal lobes and the hippocampus. Hippocampus is what we use to retain memories. So a lot of us complain, my memory is terrible, and I have experienced
Dr.
this
Robbie,
too.
I'm just going to jump
I'm
in.
somebody who
You
had
mentioned two areas of the brain,
photographic memory before,
really
and now I
key
have for people to
sticky notes
understand all over my office to tell me what I need to be doing and at any certain period of time. So just to give a little bit of a clinical perspective, I know a lot of us have had issues with that. I'm just going to reset the room really quickly. This is the In It for the Long Haul Club. Katie and I started this a few months ago to support long COVID patients, and we are very concerned about the neurological aspects of long COVID. And we have Dr. Robbie here, who is a clinical psychologist who has been spending a lot of time diving into the research on this matter and sharing her own experience as well as a long COVID patient. So, Dr. Robbie, do you want to take a couple more questions, or how would you like to proceed?
Sure, I think that makes sense before we go into the cognitive impairment section, because I think, firstly, I just want to say thank you, Dr. Alice, for making sure that we explain these things. If I gloss over them too quickly, I really, really appreciate. That's a great catch. I want to speak to what Dr. Alice said before we take some questions about the psychologizing of what is really a neurologic disease. It's, as she mentioned, an organic brain problem. This is a brain disease. And so I'm a psychologist, and psychologists and psychiatrists, we both treat mental illnesses. So mental illnesses are forms of brain diseases. And then there are specific things like neurocognitive disorders that psychologists tend to do the assessments on, which we'll talk more about. And then there's the psychological or emotional part. And I think Jody was the one who mentioned an example of feeling shame. So that's an example of a psychological experience where we might be feeling ashamed or defective or inadequate, any number of emotions that are due to what we're going through. But our personality changes that Dr. Alice was mentioning and emotional dysregulation are absolutely controlled by our brain. And our amygdala, for example, controls our fight, flight, or freeze response, right? And so we easily go into that response, and because our brain is assessing that the circumstances are very dangerous. So we have to be, I guess this is the place where I'll mention, and we'll probably talk more about it later, is this concept of being gaslighted. Many of us have been gaslighted by physicians who see us coming in and talking about these symptoms, and they immediately dismiss us as having anxiety. Now, as a psychologist, I take double offense because, and Jody can raise her hand here, I bet. Having anxiety isn't a just thing. Having PTSD is not a just thing. Having depression is not a just thing. These are serious diseases that have a severe impact on our lives and shouldn't be minimized by anyone, much less in the context of gaslighting us that how we're presenting doesn't fit any mold that they're aware of, so they're dismissing us to get us out of their ER. As many of you may have heard of the little phrase that ER docs joke with each other and say, treat and street. So their goal is to get you out of there as fast as they can. And if you're not dying, they don't want you because they need to be there for the people that are dying. And unfortunately, with COVID, what did they tell us to do? If you can't breathe, go to the ER because no one will take you in their office, right? So we're between a rock and a hard place if people won't take us seriously. Now, I think there's been a big shift, and certainly for me, making the move from Jacksonville to Mount Sinai was a tremendous shift. And I only had one experience of being gaslighted, and I fired that doctor immediately, and I called Dr. Chen and told him who it was, and he told me, and apologizing, that this fella had been pulled over to assist in the pulmonology department, but he was not supposed to be seeing long-haul patients. He wasn't in our clinic, and someone mistakenly put me on his schedule instead of, and this was to have my evaluation for sleep apnea. And so they were very, very helpful. But by then I had enough fortitude to be able to stand up for myself and advocate for myself. But there were certainly times earlier on in this journey where I just didn't have the physical, emotional ability. I couldn't articulate. I just was inarticulate. I just couldn't express myself well enough to not allow someone to gaslight me. But I have taken names, and when I am well, I'm going to make my rounds to those physicians. And when Dr. Robbie is full Dr. Robbie, they're going to have a little visit from me so I can make sure that never happens to anyone else again. Okay, so I'll stop talking now and we'll open up to questions.
Hi, it's Katie speaking. Thanks so much, Dr. Robbie. Would you like to continue, or shall we turn it to one more question? It's really up to you. I want to conserve your energy. I don't know how much time we have left of your presentation, so thank you so much.
So next I wanted to talk about is cognitive impairment. And the beginning of this presentation is a lot longer than the end because, as I mentioned earlier, we don't want to psychologize what we're going through, but we do want to really focus on the neurological aspects here. And one of the biggest is the cognitive impact that it is having on us. And so there's been a lot of studying going on to understand the neuropsychological impact on us. And so I hope that this will be helpful to hear about and understand more. So the following areas of cognition are showing impairment. They're called semantic problem solving, visual attention, spatial working memory, and attention. It's funny that I paused and like, oh, I can't remember. And obviously our memory is a huge part of this. We've all been experiencing this concept of what's referred to as brain fog. And lots of people have heard me say this before. I find the phrase brain fog very minimizing. It sounds like a very cute title for something that might not be as destructive and damaging and impactful on our lives. And so basically, think of brain fog as a loss of astuteness, a loss of cognitive clarity, a loss of attention and memory, and really a subtle loss of every aspect of cognition is possible. And that's, in order to know what's going on in your brain, you really would benefit from having a neuropsychological assessment done by an actual neuropsychologist. So when looking for credentials, those of you that may have come on later than me, I recommend that you see somebody who has done a fellowship in neuropsychology and has that in their credentials. If you can find a COVID-aware neuropsychologist, that would really be ideal. And I had my assessment done at Mount Sinai at the Center for Post-COVID Care, and my impact was that I have attention issues, and I have memory issues and visual spatial issues. Those were my three major areas of significant impact on my cognitive abilities. So there was a study that was done in 2020, and it was online, and they had they were doing a study on people that had been on ventilators, and they found a 10-year cognitive decline between the ages of 20-year-olds and 70-year-olds groups that had been. So it didn't really matter whether they were 20 or 70. There was this about a 10-year cognitive decline. Now, what does that mean? That means, from psychologists and psychometric terms, it is an 8.5 drop in IQ. And that is greater than what is even seen post-stroke. And it's also greater than that seen in people with learning disabilities. And so this is really huge. It's greater than half a standard deviation in our cognitive abilities, and that is a striking change. So many of you notice that you're just not thinking, working up to your prior intellectual ability, and that's your subjective experience. And you're right, you're not. And it's just a matter of, okay, let's get that identified, because there's something that you can do about it. And I think that's really important that we recognize that. So unfortunately, because there are so many of us, there are going to be that Lancet study that talked about hundreds of thousands of people are having cognitive changes. Millions worldwide are having it, and we need to get help. And so Shelby's group, Blooming Magnolias, is a place that you can get help and get all kinds of wonderful recommendations from her website. So I just want to put a little shout out for Shelby and Dr. Alice and the work that they have done with Blooming Magnolias, because they really are focusing on this issue of cognitive impairment, as well as the psychiatric changes and the psychological changes that are occurring. The next thing I wanted to say was that there was a study done in brain behavior and immunity, the Journal of Brain Behavior and Immunity, in December of 2020, that was entitled Cognitive Profile Following COVID-19 Infections, Clinical Prediction Leading to Neuropsychological Impairment. And I thought this was a really interesting article. And what it was done in by Almera et al. In Spain, and they found that there was a small group of hospitalized patients. So it was following their hospitalization. There were 35 patients in their cohort. They were given neuropsychological test battery, a complete neuropsych test battery. And this is what they found. They found that headaches and clinical hypoxia resulted in impaired global cognitive index, which included memory, attention, semantic fluency, mental flexibility, and phonetic fluency. And semantic fluency is being able to name words, and the test is naming words. Like they'll give you a certain thing to say, like, tell me all the different types of trees. That's not it, but I'm not going to tell you what it is. But then you have to start listing all the types of trees, and they time you. And it's actually something that you won't freak out about because nobody knows very many trees. But it's something that you should be able to name dozens of, and you won't be able to because of this. Or mental flexibility, where phonetic fluency, where you have you're asked to just they'll give you a letter and ask you to name words from that letter, and you'll repeat your letters, which is called perseveration. There's lots of perseveration that goes on, and you just won't be able to think of any more of whatever letter word that is. And of course, in any other time, you would have been able to come up with a lot more. Okay. They also found headache, the anosmia, the loss of taste, and those people that required oxygen had impaired memory, attention, executive functions, much more significant compared to asymptomatic patients. So, and then another category was the cognitive complaints they studied. And so the cognitive complaint was associated with elevated levels of anxiety and depression. But not everybody would get one or both. Some people got one or the other, or none, and some people got both. And so that's an important thing. I definitely had hypoxia, and I know others on the up on the stage had experienced that as well. And that's important to understand that, yes, and that's why we have impaired memory and this so-called brain fog. So I also wanted to give another study about the neurocognitive symptoms of COVID-19. This study was published in the New England Journal of Medicine in 2020 by Helms. And in a sample of 58 patients, 84% had neurological symptoms. That's really significant. At the time of discharge, 33% had, they used the phrase dysexecutive syndrome. That's not actually a phrase that I would use, but they're trying to talk about the executive dysfunctioning and chose to describe it that way, I think. And then they went on to use the description as consisting of inattention, disorientation, or poorly organized movements in response to command. And they had findings on MRI in the bilateral frontotemporal hyperperfusion. And and they also had EEG disorganization. So that was an important article to see that so many patients had neurological symptoms. Again, it's a small cohort because that's all we have available is to do these very small studies. It'll take a lot longer to do the large ones. There was another study of cognitive functioning done in France that was published in the Journal of Neurology, Neurosurgery, and Psychiatry in 2020 called The Pattern of Cognitive Deficits in Severe COVID-19. And this was based on 4 patients that had a normal Montreal Cognitive Assessment score, which is a cognitive tool, and 4 patients who had those first 4 patients were relatively low performance on the executive subtests. Then there were 4 patients who had mildly impaired Montreal Cognitive Assessment, and 5 patients had moderate to severely impaired scores. In the latter 2 groups, the executive functioning, attention, memory, and visual spatial functions were impaired, while their ability to speak their language and their orientation were preserved. And as I mentioned, I have the attention, memory, and visual spatial, and I have some language issues, word finding difficulties, and perseveration. So those were things that I've experienced. All right, let's see. Is there anything else I want to say? Oh, I wanted to talk about the visual spatial impairment. Lots and lots of people are talking about how they have sore, painful eyes, blurry vision, a very odd sensation in their eyes. Yes. And I'm participating in a study. The data's not published yet. I'm looking forward to hearing it. It's a Harvard study examining this, looking at this. So when I have more information, I will share that. But I have had that since day 6 of being sick. I awakened that morning with conjunctivitis, and since then I can't. I've had to have a new prescription. I've developed a cataract, and all kinds of weight, a size that I shouldn't be for my age, etc. And I bet you lots of us have that. And so if you are having it, please get seen by an ophthalmologist to really look at your eye health, and because there are significant changes that they can help with, and at least make it a little bit easier to read. And I wasn't able to read until they gave me a new prescription. My prescription changed profoundly in the few months, because I had a check before COVID started, and they had obviously my glasses to compare, and it was just a profound change in my vision. So the docs at Mount Sinai said that they could get me to about 80% better, and they did. But I tell you, in terms of vision, it's still really significant. So I know many of you are suffering from that. I also wanted to mention that for other people that are on here as people that are long haulers, and long haulers just a phrase that means somebody who is suffering with COVID long after it should have been resolved. And Amy Watson coined the term in her Long Haul COVID Fighters Facebook group for long COVID people like us, long haul COVID fighters, if you want to join on Facebook. She has different phases of groups depending on how long you've been sick, so that the material is more relevant to where you are. And so there was a case that was presented in 2020, in which a 59-year-old female presented with worsening memory impairment, right-sided weakness, right-sided headache, 2 months after the COVID-19 diagnosis. She thought she was recovered. Her memory impairment included forgetting her children's names, the names of her neighborhood supermarkets, work schedules for the day, etc. And so she had both in anterograde and retrograde amnesia. So they did a brain MRI and they found left frontal hypodensity. And but the question remains whether the lesions were also undetected perhaps in the brain stem. So we would expect to see them, but I honestly don't think, based on my experiences, that the medical grade MRIs can see some of these lesions that COVID is causing, because it's really impacted our micro vessels so intensely, and they can see it on autopsy, but they can't see it in a lot of the scans that are available. So you might, many of us didn't really notice the really significant cognitive impairments until several months into it. Anybody else on the panel flash to that, where you started a month or two into it before you started having cognitive changes? No, nobody else. Okay. So I think I will stop there with the cognitive stuff. If anybody has any questions, I wanted to say something. One other thing about this is that other people have raised this in terms of physicians hypothesizing a psychogenic nature, which is, I use the word psychologizing it before making it like you've got some less important kind of thing going on, like just anxiety, when you're presenting with these types of amnesia. Because historically, when people have both of those kinds of amnesia, and your MRI doesn't show anything, your regular MRI doesn't, or CT, they might not even get to an MRI, or CT doesn't show any reasons that you would have that, then they would say that, the hypothesis was that it was psychogenic and triggered by social isolation. And absolutely, there is no question, it can't be overstated that certainly having COVID is stress-inducing, but this is not psychogenic. What we're experiencing is not psychogenic. My guess is that they are TIAs caused by these microclots. What we refer, a TIA is a transient ischemic attack, so it's not a full-blown stroke, but there's this little blockage of ischemia. Versus there are two types of strokes. There's one that's hemorrhagic and one that's ischemic, and those can happen with COVID. But it seems for the long haulers that it appears, and we'll just have to wait and see, right? This is this hypothesis at this point, but it appears that they're microclots that are causing these neurocognitive issues. So this is Dr. Robbie out, and I think I have one other thing to say before I go out. So we're going to open up questions, and then we're going to have a second room where we'll talk more about the psychiatric manifestations like PTSD, which is a huge one, and anxiety, all the different anxieties, obsessive compulsive disorders, psychotic disorders, all of the different mental health issues. And and then we'll talk about the psychological aspect, which is much more dealing with the emotions that people are dealing with. Okay, Dr. Robbie out.
Hi, this is Katie speaking. Thank you so much, Dr. Robbie. I'm so grateful for all your time and your expertise. For those of you that have just come to the room, Dr. Robbie is a clinical psychologist. She is also a long COVID patient herself, and she has just given us a really, really great synopsis of all of the information and science that's come out so far on the neurological, cognitive, and psychological effects of COVID and COVID on the brain that many of us fellow patients, I'm a patient myself, I'm not a medical professional, I am a scientist, but, just really highlighting the severity of this disease and some really great talking points on the topic and the great studies that have been published. So thank you so much, all of you, for being here. We will be, as Dr. Robbie said, we'll be doing a round 2. So if you are interested in that, please follow Dr. Robbie, Dr. Alice, or myself, or follow the club. If you are interested in any follow-up questions or conversations, we would love to have you back. We're trying to be really respectful of Dr. Robbie's time, Dr. Alice's as well, and everybody listening's energy, as many of us are patients and experiencing this ourselves. So thank you so much all for being here. So I am going to turn it over to Anne right now, and please introduce yourself, like a brief introduction if you feel comfortable. Just a reminder to anyone that is on stage, this is being recorded. If you have a question, it's better to message in the back channel and we can relay it. Just want to make sure that everyone that's on stage is comfortable saying their name or whatever. So thank you so much, Anne. I'm turning it over to you. It's Katie and I'm done speaking.
Hi, Katie. Thank you so much. Anne, been here for 18 months, going on 19 months. First of all, I just want to say thank you so much for doing this room, for raising awareness about the effects of COVID, the neuro-COVID. That is my most debilitating thing that I'm still dealing with. Just a little backlog. I have pretty hard. I had a viral encephalitis. I still have an autoimmune encephalitis from COVID now. Apoxia clots. Basically, all my organs are hit. Most of it has resolved or is somewhat contained. The most concerning one is still the brain issues. I still deal with, I have some brain damage, but it manifests as, I appreciated someone talking about brain fog, seems so euphemistic for what we went through, because I'm like, if brain fog means like forgetting that you're a human and a woman and a parent and all that stuff, then yeah, brain fog. But I would say that was, it felt very euphemistic when they would say like, oh, so you're experiencing brain fog. Early on, it was definitely dementia-like. I mean, it was literally, I did not know where it was. Viral encephalitis, but that happened. I do also want to really appreciate the destigmatization of the psychiatric manifestations when your brain is inflamed. I know that the awareness trickling up is really impacting a lot of people. That for me, when I had the encephalitis in the acute phases, it manifested more as euphoria and dreamlike and others, but others had much different experiences. Some had, psychotic breaks and other things, they hear voices, and when your brain gets inflamed, it misfires. But I had a conversation with someone recently on, they were middle of the country, didn't really know about it. They got COVID and they were like hearing voices still, and they were, you could tell it was very weird to even bring up. He felt very uncomfortable about it. But I'm like, hey, when your brain's inflamed, this stuff can happen, and don't be afraid to talk about it. It's not a failure of you flu or a failure, whatever. This is just what happens when, you have a viral, infection that can cause all these things. So I think that that's just a very powerful thing to get the word out, because, when your brain is inflamed, you can do all sorts of tricks on you. I know a lot of us dealt with severe insomnia, which was another whole level of playing with your mind because you can't sleep. I also did want to touch on anxiety and COVID and how it's not and or, you can have both and they can play off each other, and it can be really hard to navigate that. My daughter has pretty severe anxiety. She had a COVID breakthrough infection with vax, but it was very interesting trying to help her navigate her anxiety and her panic attacks around what she was experiencing, and also dealing with the medical aspect of it and trying to get treatment for it. So it was like you had to manage both. They were two very real things. One was pre-existing; she had it before. Anyway, it was. I appreciate sort of breaking those down. I did want to talk about the memory impairment. Still dealing with that 18 months out, although it is getting better. And I just hope they still learn more. I'm still hopeful a lot of it can still heal. I still kind of exist in a halfway dreamlike state. I don't know when that will eventually resolve. It's not, I can live with it. It's just sometimes the morning feels like it's dreamlike. The time is distorted. But I also still have an autoimmune encephalitis, so I'm being treated for that. Anyway, I just wanted to say it's real. I really appreciate you guys talking about this. And you can have both. You can have, brain inflammation, and it can manifest as anxiety, and it can manifest as depression, and insert above. And just because you have anxiety doesn't mean you have also something very that can be treated and addressed in addition to that.
Thank you so much for sharing your journey with us. I think that really helps other people to, when people do share that they're a COVID long hauler and that they've had a neurologic injury, because large percentages of us have, and that's really, really important that people get to hear from others that are long haulers besides me. And as far as destigmatization of mental illness, that has been my career's work. It's just so important for people to understand that your brain controls everything in your body, and that mental illness is illness, and we really need to recognize that. So I like to think of mental health and focusing on us improving our mental health, but we can't. We have to recognize that, Anne was saying, is that people can have both. You could have pre-existing anxiety or schizophrenia or depression or bipolar disorder or obsessive compulsive disorder or whatever, or none of the above, and you can still experience psychotic symptoms. And I guess this is as good a time as any for anyone else who's come into the room since we started to mention that I am not providing medical advice and or offering treatment. I am simply sharing my personal experience as a long hauler and my knowledge as a clinical psychologist in a general way, and that anything that we discuss on here is to be discussed, taken back to your physicians and discussed with them so that they can make recommendations specific to their knowledge of you.
Rowena, my love, we'll turn it over to you. If you have a question or a share, and feel free to introduce yourself as well. It's Katie, and I'm done speaking.
Hi, Katie. Hi,
Dr. Alice, Dr. Robbie, and nice to hear the knowledge that you and insights and resources you're sharing. I am not a long haul COVID. I have not, as far as I'm concerned, had COVID. So I'm very grateful right now. And I came in here to support Katie and, with her experience with the long haul COVID. I am a former ex-aerospace working in tech for a very long time until I transitioned before the COVID began as a transformational health and mindset coach. And I've pretty much built modalities that is the most easiest way to help transform the body and mind that both connects these two parts of us as human beings. And with the COVID in mind, with all the other symptoms and health issues or health diseases that currently many population experience, COVID is something I want to learn and explore. And so my question is with you, Dr. Robbie, and I'm I really believe in interconnections. There's no separations in every parts of our beings, and so I really want to dive in deeper into connecting. How can we best? What would be your one knowledge so far with what you're doing and with what's been learned and collected with each individual's symptoms with COVID-19? What would be the one thing that you would recommend to kind of dive into a little bit deeper between ensuring that the body is not excluded into the whole cognitive dysfunction? So that would really help me kind of focus into and then kind of spread out from there. It's something I'm kind of looking into more. So with whatever modalities, tools that I have, I can really pinpoint exactly what tools and resources that would be more focused in that area that really serve best when it comes to COVID-19, knowing the fact that it has definitely a cognitive psychological effect, but ensuring that the body is kind of is also an included part of that process and healing and recovery, to bring the person back to its baseline. Hopefully that's the goal. So that is my question so far. Thank you very much, and I am Rowena, and I'm done speaking. Thank you.
My one thing is to describe to you the process that the neuropsychologist team that did my evaluation at Mount Sinai recommended to me. And that was to continue to work with the neuropsychologist on the deficits that I have, as well as participating in a cognitive rehabilitation online treatment intervention. I participate in trauma therapy. I have a trauma therapist. I participate in music therapy. I have been a part of a long-term Mount Sinai My Me nutrition study. So ensuring that you are eating healthily and really consistent with what COVID requires, and having appropriate supplementation that our bodies need, because COVID is really tricky in using our nutrients in ways that are unique, and some not so unique, but for the average person, they wouldn't have known about vitamin D's importance in this viral disease, or the levels of vitamin C that are necessary, etc. And then I think the physical rehabilitation that will come much later, and that was one of the lessons that we learned at Mount Sinai, is that when they started me on physical therapy, even though I was doing 5 minutes on my own, I ended up in the hospital for 5 days. And then they started moving me, so it was inactive movement, and I ended up in the hospital. I was essentially went into a delirium, and I had to be taken by ambulance down the street to the main hospital. So those are the things that I've been using, and I'm on a ridiculous number of medications that I shared. I was on no medications before. I took a few supplements, vitamin D and magnesium and calcium and omegas and vitamin C before, but that's it. And eat really healthy, lots of fruits and vegetables, and lean meats if you're a meat eater. I'm a pescatarian, so I eat fish. So I hope that is helpful to kind of focus on a multidisciplinary team approach rather than the siloed approaches. And so that's what I've found the most helpful to me. I hope that answers your question. Please come back, Dr. Rabia.
Thank you, Robbie. I really appreciate that. I kind of agree with more. I just wanted to get your insight based on your experience with this condition, and also your what's working for you and what's not working for you. One last question, if you don't mind. I wanted to know, there's been proven intensive research, the power of healing together as a collective, and I'm talking about community rather than just not only just one-on-one, but also in kind of bringing more of a collective approach to additional to modality in terms of mass support. And obviously, with thank God to Clubhouse with its technology, each individual can actually create their own clubs really specific to that need or that problem that we're seeking solutions to. And what is your thought on continue to have the power of community-based healing, health, I guess, approach that I think should be modeled into the medical field, into the healthcare system, and why? Thank you.
Another fabulous question, Rowena. I really love that. Yes, it is well known to psychologists that healing together as a collective is really a fantastic thing to do. In our profession, we refer to it as group therapy. And but we've really created through our support groups on Facebook and on Clubhouse that we recognize this concept, which I'll refer to as universality of the human being, that we don't know each other in the depth that we know our best friends that we grew up with, or our college friends, the people we see every day, but we know each other in actually a much deeper way, because we share with each other our innermost fears and worries and concerns and experiences, our physical, emotional, spiritual experiences, and that universality of the human condition, I think, is really essential for our healing. And so, yes, I think that is super, super important. And my husband found the long haul COVID fighters on Facebook because I was too sick. I couldn't even see to read anything, and I hadn't watched television or been online or read a single thing until he told me I needed to get on that group. And then from that is where I got connected to Shelby and to, I think, Dr. Alice and a number of people on here. And I think that you are so spot on that the medical community would really benefit from having often, and I think it really comes down to where we decide to put our money when it comes to healthcare, and I think that's really been problematic. And but here we are, we're providing each other support for free, and we can get a lot of support from one another, and provide information to one another, to take back to our providers and save each other a lot of money by saying, oh, no, that's been debunked, or, oh, yes, this is a great thing to consider. You have, 1,000 people on your group saying, yes, I've done this and it's been really effective, then you're more willing to spend some money to try those things than if everyone comes back and says no. So I think having the collective-based healing concept is a really great way of framing it. And I just want to thank you for framing it that way. And so I agree that it's essential. Dr. Rabia.
So great. Thank you, Robbie. Thank you, Katie, for having this space. Thank you.
Hi, it's Katie speaking. Thank you so much for being here, Rowanna. I really appreciate your support, and to all of us in the community as well. So thank you so much. I really hope that helps, and agree, just not in terms of any medical advice or therapeutics or anything, although Dr. Robbie referred to group therapy, but I think there is also value in many of us reaching out and finding support in communities like this here. So thank you so much. I know we have Joyce and Amanda. You there for real this time?
I'm here. I'm really here. I'm so sorry about earlier. The app was acting so wonky. I do have a question for Dr. Robbie and maybe Dr. Alice. With my COVID infection, it hit my, for those that don't know, it hit my brain, it hit my eyes, it hit my lungs. I now have diabetes, it hit my pancreas, have constant burning electrical current throughout my whole body, except for the left side of my face. Left arm, both arms, both legs, both breast, and the right side of my face. I never thought I would prefer one side of the face to the other, but yet here we are. Which that diagnosis came back to show small fiber polyneuropathy after a skin biopsy. I did notice that I had an episode in March and April where my brain basically broke, is the best way I can describe it. People around me were saying that, it sounded like I had way too many margaritas, and the only thing I was drinking was water and Dr. Pepper. My legs gave out. I had to go and start using my walker to get around. Wasn't exactly having seizures, but I was having these jerking. They're more than twitches, but not really convulsions, like this jerking motion thing. And I have noticed that when I get super stressed, it hits the right side of my body really bad, and my arm will start shaking. My leg starts doing this jerking circular motion, which is really weird, and my head starts jerking. And Wednesday night at church, and I'm wondering if I have a new thing to try to start watching out for. But I don't know if I was just overly stimulated, or if something was going on with I guess my central nervous system or something. But it was like I had a tick, and my head would just start jerking, and it pretty much just jerked the whole service. My cousin was like, that would drive crazy. And I'm like, yeah, welcome to my world. And I know you can't really give any type of medical advice or anything like that, but any tips or recommendations of what I can do to try to limit that? Or, just, I guess, keep my butt at home and not stimulated or stressed? I don't know. It's, but yeah, I'm Mandy and I'm finished. There we go.
I was having trouble hitting my button. Okay, Mandy. Gosh, you sure have been through it. Thank you so much for sharing what you have experienced. And it is really quite a traumatic journey that you've been on. And I think it's always fun to have a little giggle when you said my brain broke. And I love how you share. You sounded, your friends were suggesting that you were inebriated, so I guess you were drunk on that Dr. Pepper. And but I think that what you bring up is a really important question about what's happening to your body. And while I'm not a physician, I'm a psychologist, what you're talking about, myoclonus, and it's basically when you have these sudden twitching or jerking of muscles or groups of muscles, and it's a clinical sign, not an actual disease. You can't control it or stop it, and it can certainly be brought on. We know this is I don't know if I mentioned it earlier, but it's one of the neurologic impacts, and so you can have just sudden muscle contractions. Your muscles can just get very, very relaxed. You can have a sequence of jerks or a pattern or not a pattern. It can happen a bunch of times or just a little bit. It can be in response to an external event, or it could be when you're trying to make a movement. And so there are a lot of different reasons for it. And the common reasons are an injury in the central nervous system. And you've had that. You've definitely had an assault on your brain. And so that is definitely something that I want to encourage you to bring to the attention of your neurologist, because you've got a lot of neurologic issues going on. So that might not seem like any big deal, and it may not be anything at all, other than your muscles are super fatigued, and because of, you're having burning electrical current everywhere but the left side of your face. So that definitely needs to be discussed with your neurologist or neuroimmunologist. I'm not sure if you've got one or both of them working with you. So I hope that's a helpful response. I'm so sorry that you're having that. I know lots of people report it, so you're not alone, Mandy. And I hope just knowing that is helpful to you as well. Dr. Robbie out.
Thank you so much, Dr. Robbie. The regular neurologist, did figure out that the burning electrical current was the small fiber polyneuropathy. They wouldn't see me once, after my broken brain episodes, until I had all my tests finished. And now I've gotten the biopsy results showing the small fiber polyneuropathy, and he's referring me to a muscular neurologist. He won't even see me. He's done with me now. So, he's just kind of passing the buck on. But it did make perfect sense, and thank you so much. I know this takes a lot out of anybody, especially someone dealing with long COVID. So I just want to let you and Katie, Dr. Alice, know how appreciated all of you are. yourself so much. Y'all are like the bomb diggities. So thank you.
Thank you, Mandy. That's so sweet of you. I want to say what I would have done, which is just, again, my experience, not medical advice. If I sounded like I was drunk, it would have raised a red flag for me as a psychologist, and I would have gone to the emergency room, because that's really suggestive of a neurologic event happening right then. And Dr. Copeland,
I went to the ER, and the only reason why they let me go is because I had an appointment with my neurologist, and the neurologist canceled the appointment because I didn't have all the other tests done. So,
oh my goodness.
Yeah, it was fantastic.
So frustrating. Well, of course, you can go up the food chain and go and see a neuroimmunologist. They're the big daddies in dealing with neuro-COVID. And so I'm not sure where you live, Mandy.
About 35 miles or so northeast of Atlanta.
Okay. So they do have the COVID center at Grady. I'm not sure really what goes on there, but if they maybe have a more COVID-aware neurologist that might help you. You're probably sick of thinking about even doing that, but if you could get into a study that would do a really top-grade brain MRI, they might point out some of the explanation for your what you described as your brain broke. And so thank you so much for sharing your story, and thank you for being so appreciative of what we're trying to do today, because we're all long haulers and trying to help each other. Thank you. Dr. Robbie out.
Hi, it's Katie speaking. Thank you so much, Dr. Robbie, and thank you so much, Mandy, for sharing your story. As you know, I have had very similar journeys to you, and I also sound like I'm drunk a lot of the time. I've improved a lot. However, especially after talking for a bit of time, I stumble over my words. I am now, but I'm definitely improved, but how I was. And I just want to give a little bit of hope for anyone that might be listening in, anyone that's known me over the past 6 months or whatever that I've been speaking on this app. I've definitely improved. I know many of us have. We have our ups and downs, but that's great advice to take it very seriously when that takes effect, and to go see a neurologist. So I really appreciate that advice as a friend to anyone that might be listening in and experiencing this, because I do think a lot of this is very serious, and I do hope that people can seek medical care, and I hope that we can research this more so we understand what's happening as these neurological and cognitive impairments are very severe. So I just again want to thank everyone for your patience. I know that we have Joyce and Dr. Copeland waiting on stage. I know Andrew wants to ask another question too. So Joyce, I will turn it over to you. Please introduce yourself and your question or thoughts on the topic. It's Katie London speaking.
Hi, my name is Joyce Waterhouse, and I really appreciate all of you, and as you will be able to tell, I can really relate to all the difficulties you're going through. I developed ME/CFS about 35 years ago after 2 viral respiratory infections. They didn't seem particularly serious, but I had 2 in a row, and this happened while I was getting my PhD. And I became fatigued and gradually worsened, and eventually I became disabled and bedridden. I lost a lot of weight, and this was after my first postdoc in my 20s. So I know ME/CFS is not the same as long COVID, but there are indications there may be some overlap. And as you may know, research is showing that ME/CFS patients also have neuroinflammation. So that appears to be, in common, although who knows what the similarity is in terms of causation. But I'm trying to figure out whether what I learned that allowed me to get well and that I'm trying to develop might help in long COVID, at least to some degree in some proportion of patients. And my question is whether you know of anecdotal reports or research related to the role of food allergy or hypersensitivity. I know you've mentioned, a healthy diet, but more specifically, the food allergy and hypersensitivity in relation to long COVID symptoms. I asked because I had very extensive food hypersensitivities, and I think it was the biggest underlying factor in my illness, and it included huge effects on brain fog, anxiety, fatigue, headaches, that kind of spacey feeling, memory, basically every symptom, I would say. And it was also huge in my symptoms of POTS. My heart rate would go up, like 30 or 40 beats a minute standing, or even more just walking across a room. And so I have a hypothesis that the immune activation from the virus might cause your immune system it's being overactive. It might start reacting to a lot of foods and other substances like inhalants also. And actually, from my long research on this issue, I do think, the typical idea of a healthy diet and reducing processed foods, from my own research, indicates that does tend to lower your exposures to the worst sources of hypersensitivities. But for some people, that may be not enough, that even foods that are healthy, they might be reacting to, and so on. But anyway, I just thought I would get your perspective on that, if you have any insights on that issue. Thanks so much. I'm done.
Thank you, Joyce. Wow. 35 years of suffering with MECFS. Thank you so much for sharing that with us. And I think you are probably very well aware of the collaboration going on between ME and long COVID. And we've been working together to lobby the Congress to have funding to really study things like you mentioned, the studies that are going on. And so I definitely, personally, am interested to hear what allowed you to get well, because I think that there are a lot of overlaps, even though they are different. There is a tremendous amount of overlap, and I am absolutely aware of the research going on right now with the MECFSers looking at the inflammatory process. So as you brought that up, I can share my personal experience, and maybe some others might be able to share. Dr. Copeland might be a great source for us to share some of the research on it. But I think I mentioned earlier that I've been in a long-term study with Mount Sinai, and I meet weekly with a nutritionist, and I have to take photos of every single thing I eat and drink and record that, and then my symptoms relative to what I'm eating and drinking. And that was to try to address the profound GI and the allergy symptoms that I was having early into my experience with COVID. And so the kind of diet that they have me on, I joke sometimes that I actually am eating a less quality diet because the fruits and vegetables that I was allowed to eat before have been so severely limited, and you mentioned that. And I bet you've experienced that same thing, that you had to really limit. Another thing that Mount Sinai has us doing is I take Claritin 3 times a day, and that's because of these, the runny nose, the constant, the sneezing and the coughing because of the mucus, etc. That seems to be like an allergic reaction, but it's pretty much happens every single time that I eat, regardless of what I eat. And so I don't think they really understand it fully yet, but I'm on a low histamine diet, and I'm also on a, oh gosh, my brain just froze. No dairy, no gluten, and there's something else that I'm not remembering at the moment. But basically, that's what we're doing from Mount Sinai is really limiting things. So I'm not allowed to eat a lot of fruits if they're high histamine fruits. My vegetables all have to be cooked. So I used to eat lots of raw vegetables. I can't have raw vegetables. So there are a number of things that have been taken out of my diet because I would have really severe GI issues, and I think it was all contributory in terms of the way the gut has been impacted by COVID, and this concept of a leaky gut and that crossing, things crossing the blood-brain barrier from the gut. But we also, many of us have been on lots of different antibiotics, which is crushing the microbiome, and we have to build that back. So there are a lot of different issues. It's really complex.
Hi, it's Katie speaking. I really appreciate your solidarity, Joyce, and interested in the food connection with long COVID and COVID health and everything like that. So we can certainly have a discussion about that another time. I find it really interesting. I just want to respect everyone's time. We've been here for 3 hours, and for us long COVID patients, that's a lot on our brains, as it is for many people just listening in the audience too. Dr. Copeland, I know you've been waiting so patiently for so long, so I really appreciate you introducing yourself, and if you have any questions or thoughts on the topic, we'd love to hear from you. So thank you so much. It's Katie, and I'm done speaking.
Well, thank you. I appreciate that. I think this is a great room. I had a question for you guys. So talking about like the mechanism of brain fog, I think it's really interesting. So like when we see respiratory illnesses that cause like meningitis, right? There's a couple ways it can happen. Like the virus can hitch a ride to the brain on the olfactory nerve. All right, going through the nasal cavity. That's one way it can happen. Another way it can happen is, obviously if you have a compromised blood-brain barrier, that can happen, but that's really rare. My question is, do we think that the mechanism is like a more generalized mechanism, like maybe people that have COVID-19 and they have a really rough time have some kind of like microvascular issue, like the stroke volume increasing, they have like miniature strokes throughout the process of the COVID-19, which is contributing to their brain fog? Maybe there's some kind of like neurological remodeling going on? Or do we think it is literally like a form of meningitis where SARS-CoV-2 is kind of hitching a ride and somehow, I'm genuinely asking, I don't know, like is it somehow hitching a ride and it's actually causing an active infection of neuronal tissue? So that's my question. Like, what's the whole mechanism, surrounding like brain fog? It's really tricky to kind of down.
Hey, this is Mandy. I know when I had my initial COVID infection, when I started having the electrical current feeling, I was admitted to the hospital for 5 days because they thought I was having a stroke. But all the testing and stuff showed that I wasn't. So I don't know if that would help answer your question or not. This is Mandy, and I'm finished.
No, thank you. That's definitely valuable. I think that, I think, look, again, I think it's two subsets. I think some people may have, like we know some people that have COVID-19 have strokes. That's a fact. But what's kind of odd to me is that, like, we see people that have brain fog that had COVID-19, but they weren't, like, septic, or they didn't have, like, a really bad case. Or some of them weren't even hospitalized, and they still come out with brain fog. So that's kind of like my question, is what do you guys think the mechanism of this is? And I think it's really important for, like, research and this kind of stuff to kind of say, oh, we think it's this, we kind of go in that direction. What do you guys think is the mechanism?
This is Dr. Alice. Thanks for the question. I think a lot of this is vascular, as you said. So we know that SARS-CoV-2 basically, if it has a blood vessel, SARS-CoV-2 is going to find it. And there are a lot of what they think are microvascular changes that are happening. I had micro bleeds as well in the brain that were found afterwards. I think it's that. I think it's persistent hypoxia. There are some people who are literally still on oxygen after 18 months, believe it or not. And so the hypoxia in and of itself can cause in my case, it was complete confusion and delirium, and I was not in the hospital at the time. And then the third mechanism, I think, is this profound dysautonomia that's happening that might be causing hypoperfusion at times. So I think it's very complex. I think in some cases it's probably direct brain damage, but in other cases it might be a perfusion problem. But all that said, this illness is extremely tricky because it's vascular. So people say, well, how the heck could you be fine in the morning and then in the afternoon you're a mess? Well, when vascular tone changes, it's very typical that someone would have symptoms at one point and not have it at the other point. We see that in microvascular angina in the heart and macrovascular angina. And I think it's probably the case here, even in the respiratory issues that people are having. So you'll hear also, and I am one of these people, my lungs actually did not look bad the whole time that I was sick. But I probably very early on had some sort of early pneumonia, but thank goodness does not look like I have permanent damage to the lungs. However, I was persistently hypoxic until about 11 months out of my illness, requiring supplemental O2. So my hypothesis is that, again, this is all a vascular phenomenon, and inflammatory and hypercoagulable and kind of a perfect storm for everything. And that's why I think, that's why I try here I go with my brain fog. I keep trying to emphasize that, this is more than just people being a little tired. This is actually a vascular issue. The other thing that we're seeing people having clotting events 6 months out and longer. And to me, that's extremely frightening too, because it seems as though this vasculopathy or whatever's happening because the damage from the virus is persisting in some people. So, it's still a complete mystery. And I guess we'll see with more research. This is Dr. Allison Dunn speaking.
I'm sorry. I was just going to say I agree with that 100%. And one thing I actually propose, and I'm going to try to write a grant to this effect, is to use ambulatory blood pressure monitoring to look at increases in blood pressure after people have had COVID-19. Because if there is some kind of vascular remodeling, you would imagine it'll contribute to some kind of vascular stiffness, and you can measure that using a vascular stiffness index. So, no, I agree. I say all that to say I agree with that 100%. I think it likely is a vascular issue. That was my thing as well. Thank you.
This is Dr. Alice. Yes, I think that's an incredible proposal. As a cardiologist, I'm seeing a lot of people with what we call labile blood pressure after infection. But in the long COVID population, there are people having almost hypertensive emergencies at some times, and then it's completely resolving. So there is definitely something going on with the endothelium and vascular tone and things like that. And I think that's a great project. This is Dr. Allison Dunn speaking.
Dr. Copeland, thank you for that really great question. Earlier on, I was talking about it. We didn't go into great detail about the mechanisms. I think some of the research that I've read has talked about the ACE2 enzyme, and it's in so many organs, and so it's expressed in the nasal cavity, epithelia as well. The olfactory epithelium is another, obviously it's an early infection site. So that's one hypothesis, is that SARS-CoV-2 enters the brain via the olfactory nerve and the olfactory bulb.
Hi, it's Katie speaking. I just wanted to say firstly, thank you, Dr. Copeland, for your amazing question, and thank you for your sorry, excuse my long COVID brain, but thank you for your interest in the subject and wanting to research it further and look into grants. I just also wanted to say thank you, Dr. Robbie. I know that this is a lot on you as a fellow long COVID patient, so there is absolutely no worries taking a break. And did you want to respond now? I can turn straight to you if you would like.
Yes, sorry, I had to get a drink and clear the mucus from my esophagus. I apologize. So I wanted to share a study with Dr. Copeland. It was published in the Annals of Neurology in 2020, called COVID-19, a Global Threat to the Nervous System. And in that study, they talked about the number of recognized neurologic manifestations of COVID is accumulating. And so their view is it's a variety of mechanisms, including virus-induced hyperinflammatory and hypercoagulable states, direct virus infection of the central nervous system, and the post-infectious immune-mediated process. And my experience at Mount Sinai is that that's basically how they're conceptualizing it still, is that it's these multiple possibilities, and trying to understand it. So the more studies that are done, the more information that we're going to have. But I think you were asking about strokes, and do you, see if I get this right, you were asking, do we think that people are having strokes or TIAs? Was that part of your question, Dr. Copeland?
Yeah, so yes, absolutely. Thank you, Dr. Robbie. I think that it's been shown a couple of times that people that have COVID-19 tend to also have an increased risk of stroke, especially those that are African American. And I think that, and that's why I kind of wanted to ask about what you guys thought was that I've always kind of suspected that obviously it's complex, but the bulk of it is just like when we did. It's a study that looked at one of the Centurion studies that looked at like the brains of people that were in their 90s, 100 years old, and they looked at the causation of dementia, and they found that it wasn't like it wasn't amyloid plaques or that typical kind of like taoism those tauopathies rather that you see with the Alzheimer's disease. It was actually microvascular. It was a microvascular issue, and so that's kind of what I thought it was really interesting. I was like, wow, so that kind of showed us about how dementia actually works. It's not always a big stroke or Alzheimer's. It can be these very small miniature strokes you get throughout life. So that's why I was thinking, if you have like really bad case of COVID, however it's doing it, maybe it's increasing stroke volume as a result of like vascular remodeling. Maybe when you're really sick and you're like virtually septic and you're on death's doorstep, you get like these kind of like miniature strokes. But I've always kind of thought it was a miniature kind of like a microvascular issue, as Dr. Allison. So yeah, that's what I was kind of speaking to. What do you guys think about that? Or if there are any other? I know you guys are a lot more in the field than I am, so I was just trying to get like ideas on that. Thank you.
Well, I'll tell you what my experience has been, Dr. Copeland. On the very first day when I awakened 2.5 hours late for work, I had the symptoms, the normal symptoms in the morning, the headache, the sore throat, the coughing, etc. And then about 3 o'clock in the afternoon, the left side of my face and my left side of my nostril, left side of my lip all went numb. So I went to Mayo Clinic emergency room, and they immediately did a CT, and I had a blood clot in my right middle cerebral artery. I was given low dose heparin, and which was the recommendations of someone for COVID people at that point, which turned out to be a really, really good thing to do. And I had the multiple doses of that over 12 hours. And then 36 hours later, when I was finally able to get the brain MRI, because at that time they were really uncomfortable letting people with COVID get MRIs. So I had to be at the end of the day where they could clean it after me, etc. And the blood clot was gone by the time I got it. And so at that point I was diagnosed with having a TIA. And then about almost to the day, a month later, I had what is commonly referred to as COVID toes, but mine started out as a stabbing in this very engorged blood vessel on my right foot, and I was getting stabbed with an ice pick in the top of my foot, and my feet, both of my feet, were purple, and my blood vessels were huge. And I called my neurologist, and he said that he thought I was having microclots, and so then so I totally am a believer from my personal experience that we're having microclots. And so your idea of looking at that, I think, is very, very interesting. And later on, 3 months, again, almost to the day, I developed sudden onset atrial fibrillation and was hospitalized. It took 10 hours to chemically convert me to normal rhythm. And so I had been on a lower dose of Eliquis because of my body weight, but as soon as I had the AFib, they put me on the 5 milligrams twice a day instead of the 2.5 twice a day that I had been on. And I think there really is, and my brain studies suggest that as well, based on, again, I'm an N of 1 in studies being done at Mount Sinai, but they tell you the results when you have abnormalities. So I was fortunate to learn that I have lots of lesions in my brain. So I hope that's helpful to you and answers your question, Dr. Robbie Allen.
Hi, it's Katie speaking. Thank you so much, Dr. Robbie, for that response, and Dr. Allen as well. And thank you, Dr. Copeland, for your amazing questions and interest in the topic. Certainly, as Dr. Robbie has said, there have been some unusual events a lot of us have experienced. So I'm sure that many of us would be very happy to share our personal stories with you. Again, not based on medical advice, because we'd really like to advance the research and the science on this, but that is not known. stumbling over my words. I really need to get some fruit in my mouth. But I've also had some very strange feet and leg problems that many people in this room, and I'm not going to go into it, but it seems to be unexplained, and I've got some interesting photos of it too, but many people have these stories as well, so we'd be more than happy to, whoever wants to share stories with you if that would help you in any way, and thank you again for being here and your interest. As I said before, we've been going for 3 hours now, and I know Andrew also had a question. Please, Andrew, ask your question. It's so great to see you, and thanks for your patience. It's Katie Minton speaking.
Thank you, Katie. Thank you, everyone. Thank you, Dr. Robbie. And I'm actually going to make this short and sweet. And instead of my questions that I'll hold for part 2, I would like to donate that time back to Dr. Robbie so she can go rest. She's been doing it for 3 hours. I've only been here for 2. And I would prefer her to rest and answer any question I might have.
How incredibly altruistic of you, Andrew. Thank you so much. Thank you very much.
Hi, it's Katie speaking. Andrew, that's so very sweet and respectful, and I know you know our journeys as well. So I would just really like to invite anyone else again, please hold on to questions. We could talk about this for weeks. Neuro-COVID, cognitive, psychological, and brain effects as a result of COVID-19 and effect on long COVID is a really important topic. There's some amazing science that has been published, and there is still so much to explore. I just want to thank Dr. Robbie, Dr. Alice again for an amazing conversation. Thank you for all the great questions we've had so far. I'll turn it over to Dr. Robbie if you would like to. You have absolutely, reserve yourself, but if you want to share any final thoughts, please go ahead.
Well, I would just like to say thank you to everybody who came into the room today. And we've had a really large crowd over the 3+ hours. And I hope that this has been helpful to share my experience and the knowledge that I have to all of you. And just want to say thank you very much for giving me the opportunity to share this with all of you. I appreciate it very much.